So as we go into revisions now, which of the following is true in a 30-year follow-up Charnley low friction arthroplasty? These are cemented components. So what's the most common reason for revision surgery? The acetabular component was the least common reason. Number of revisions required for periprosthetic fractures were higher than for deep infections. Acetabular component was more common reason for revision than deep infection. Femoral component failure was a more common reason, deep infection. So what we have to look at is this was a cemented Charnley, and the acetabulum is the most common reason for failure in cemented implants. Cemented acetabular components were the weak link in the system in all of these old cemented cases. The other answers are not even close. So what are the main indications for revision surgery? Instability, malalignment. These are the two real main reasons. Instability can be because of abductor deficiency. Malalignment is the acetabular component is not adequately positioned. So again, the most common reason for revision of the Charnley low friction arthroplasty was acetabular component revision. These other particular, this is more old information. Now we don't really cement femoral acetabular components anymore. So there are higher complication rates with revisions. Again, dislocation. Now the most common reason for reoperation. Nerve palsy and deep vein thrombosis. But what concerns you the most is going to be dislocation. That far outnumbers every one of these, with the exception of with infection being second and fractures gaining. But again, dislocation is the biggie. So as we look at bone loss, as we jump to bone loss, because the other speakers tonight will have talked about those other complications, we need to classify bone loss. And the two most common classifications used is the AAOS classification and the Paprosky classification. The AAOS is something that we'll look at first. So when we look, we have to determine before we go in, and you want to get as much information as you can out of the radiograph as to what has gone wrong with the acetabulum. In this particular case, we have a 72-year-old female, uncemented total hip, 2 years ago, complains of right hip pain after a fall. Current radiograph, which acetabular bone graft describes this option? Well, patient was doing well, falls down, develops pain immediately after the fall. We have to look at fracture as the main reason. So when we look at this here, we have to make the diagnosis. So what we have to know here is this acetabular component, compared to the opposite side, has perforated the medial wall, and this would be consistent most likely with a pelvic discontinuity. This is a discontinuity till proven otherwise. So what we would be looking at would be an AOS type 4. That is a discontinuity, treated with a cage, and you got to fix the fracture. So let's go into this in a little more detail. And obviously that's the reason why it's a discontinuity, because patient asymptomatic. When you see that x-ray, there's no way that patient could be asymptomatic with an x-ray that looks like that. So one of the treatments now, or one of the tried and true treatments in an acute fracture, has been a posterior column plate, and some people are using porous coated components, but certainly anti-protrusio cages are still used quite a bit, although the pendulum is now shifting with the highly porous metals that are now available. So Here is the AOS classification of bone loss. It's more of a kind of a descriptive term. One, segmental loss of a rim, cavitary, meaning kind of volumetric loss, combination of the two, then discontinuity. In type 5 arthrodesis, we really don't pay a lot of attention to that because it's very, very rare nowadays. So here's an example of a cavitary defect. You can see that this represents volumetric bone loss due to osteolysis. Here's a combined deficiency. The component has migrated volumetric loss as well as some segmental loss. And type 4, as we showed in the question that we did, this is protruded medially, and you have to be very suspicious that there's a fracture between the superior and inferior aspect of the acetabulum. Now the Paprosky classification is more based on radiographic evidence of what is left that's available for fixation. So a type 1, minimal deformity, completely intact rim. A 2A, superior rim loss. All of these have lysis. A type 2B is a migration of the component superiorly. So the difference between an A and a B, an A is more of an expansion with an intact rim. B is a migration with a rim that's not intact. And C is just complete straight migration creating a protrusio. What's important is when all of these cases have less than 3 centimeters of migration, the cups are stable and no secondary fixation is needed. A type 3A defect from 10 a.m. to 2 p.m., superior lateral migration, and what I just like to add here is all of these, the migration is greater than 3 centimeters. That means the cup is not stable on its own. And the 3Bs, even a bigger defect from 9 to 5, but the migration is up and in. Superior medially means up and in. And the type 3s, the migration is greater than 3 centimeters. So when you measure it on an x-ray, you'll see that. And this is how we'll go through these. So type 1, there's no migration whatsoever. The rim is completely intact. A 2A, you can see this is volumetric bone loss and very minimal migration. You can see here the 2B, we have superior migration. That means the rim's not intact, less volumetric bone loss, but again, migration less than 3 centimeters from the teardrop. The 2C is just medial protrusio migration, but again, all of these type 2s are less than 3 centimeters of migration from the teardrop. All can be treated with a porous coated cup. Now look here, the 3A, up and out, large superior rim damage, but now we have greater migration from the teardrop. Secondary fixation is going to be necessary. And finally, this is a disaster. This is way above 3 centimeters, up and in, 9 to 5 bone loss. This requires a complete major overhaul, major reconstruction. When you see that, you go to the most common kind of, the most difficult reconstruction that's in your choice. Now we'll go to the femoral classification, AAOS femoral classification, kind of along the lines of the acetabulum, segmental, 2 is cavitary, 3 is a combination of the two. A type 4, it's somewhat bent, and 5 means stenosis, 6 is a fracture. This is not really, does not give you a sense of it's more, this femoral classification is more for for using this for description, for research. It's not that treatment oriented. So when we look at this, this is cavitary. It means the metaphysis is expanded. That's what it says. A combined defect here means that there's some proximal bone loss, and there is also a chunk of bone that's also missing from the femur. As we get into the Paprosky classification, it is more implant oriented. Again, minimal metaphyseal bone loss of type 1, any implant can be used. Type 2 is metaphyseal bone loss only, which means you have a completely intact diaphysis, short diaphyseal implant. A 3A means you are now involved in the diaphysis. We're now going to go with a longer stem. We have 4 centimeters intact, so we can use a cylindrical stem. A 3B, less than 4 centimeters of isthmus. We now are going to be, fixation is going to be more difficult as we get down distally. Much different when there's less than 4 centimeters of isthmus because you don't have the rotational stability. And type 4, there's no isthmus whatsoever, and we'll get into that a little bit later. So this is more of an implant selection based on the ability to get fixation in the isthmus. So when we look at a type 1 here, no metaphyseal bone loss whatsoever. A type 2, diaphysis spared, but bone loss in the metaphysis. A 3A, metaphysis is extensively involved, but as you look at those 2 horizontal lines, greater than 4 centimeters of isthmus, further destruction of the diaphysis, but still some isthmus present, but less than 4 centimeters, but there still is some isthmus, so you can possibly get some implant to be stable. And then the type 4, complete diaphyseal and metaphyseal damage, and just a hollow tube, very difficult to get fixation. And that tells us that our implant selection changes as we go further down the femur. How do revisions present? Groin pain usually means acetabulum, thigh pain, femur. Startup pain, component is loosened till proven otherwise. Night pain means there is an infection till proven otherwise. Pretty simple, but very important to take this particular history. Radiographs, we want an AP pelvis and a orthogonal views of the involved hip, AP lateral, and a full-length femur. We want Judet views to assess the column of the acetabulum and try to obtain immediate post-op radiographs to determine whether or not there's been migration of the acetabulum or the femur. CT scans are very useful to estimate osteolysis, since you don't want to get in there and just have used a radiograph and then be sorry you're in there because there's way too much lysis to deal with. Also, CT scans are very useful to assess component position. You must make sure there's no infection. So you have to do a SED rate, CRP. CBC is not that helpful, and we recommend aspiration if SED rate, CRP is elevated, or if you're very suspicious of an infection. So let's look at an example here and try to put some of this into practice. You have a 74-year-old man with startup pain, hip 10 years ago. So we have a comparison radiograph, immediate post-op on the left, current radiograph on the right, aspiration, 1,000 cells, normal SED rate, and CRP. So if we carefully look at this x-ray, we can tell that that stem has sunk. It's below where it started out in the post-op x-ray. That's why it's important to always obtain post-op radiographs. So what's our choice? Well, obviously it's not infected, so we're not going to use an antibiotic spacer. Removal of femoral component, long fully coated stem. Revision to cemented stem. We don't use cemented revisions anymore. Femoral component, allograft, prosthetic component. No. What classification is this? This is basically a type 2 because the metaphysis is involved, but the diaphysis isn't. So it looks to me like we're probably going to have type 1, simply revision of an uncemented component because this is symptomatic aseptic femur, no evidence of major defects, so we're dealing with, at worst, a type 2 defect. These are treated very well with a cementless porous-coated component. We no longer use cement, not much of a choice. So again, this was minimal metaphyseal bone loss, somewhere between a 1 and a 2. These are, we don't see a lot of ones, but this was very, very minimal damage, and that's why we were able to do that. So, next example, a little more complicated, 71-year-old male, underwent a total of 10 years ago, began having hip and thigh pain 18 months ago. Pain has become excruciating. He can't walk. Mild pain with internal external rotation. Laboratory values, the CRP, SED rate, basically normal. Elevated WBC, but in my opinion and experience, we have not. The serum values, no. If that was an intraoperative cell count of 10,000, that's different. So, what's the choice here? So we look at this classification. So this looks like it's probably going to be a bad 2 or approaching a type 3. So our treatment of choice here, does it look like that stem is loose? Are we going to revise the femoral component? Well, if the stem is loose, what are we going to put down into the femur? So obviously we're going to cable, we're going to use a fully porous coated stem, but we could use a modular tapered stem in this particular situation, but still in this type of 3A, we're still able to get away with, as I mentioned before, we got greater than 4 centimeters of isthmus, which we can see here, we definitely have, then a cylindrical stem is good, and we can use onlay grafts in the metaphysis. So when we look sort of in summary, as we go here, the uncemented extensively coated stems, porous coated, grit blasted, or modular tapered stems are excellent in type 2s and 3As. You can kind of take your choice, whatever you're used to, and it's 95% satisfactory results in many series at 10 years. 3B defects, as we mentioned, less than 4 centimeters, and type 4s. Let's look at the 3Bs first. The use of fully coated stems results in a very high incidence of subsidence. We have now gone to using, in these particular cases, many people are going over to using modular tapered devices. Impaction bone grafting is still an excellent option, but is not as commonly used in this country anymore. Still used in the United Kingdom. And the type 4s, where there's no isthmus whatsoever, just a hollow tube, for many years, allograft prosthetic composites were used in this case. That is, the proximal horrible bone was replaced with an allograft since the metaphysis was non-supportive. And in the more infirmed patient, the proximal femoral replacements were used. Again, you know, impaction grafting has been tried, but it's very difficult. And now we're extending the use of tapered stems, but there's only a limited amount of data in this. Indication for cemented stems, elderly, low demand, irradiated bone, but the outcomes are not good. If the patient has a limited lifespan, I think this is still an alternative. What about the acetabulum? Porous coated hemispherical cups secured with screws. If the rim is competent, that is all of those Paprosky type 2s, these have worked extremely well. So However, what happens when we look at this picture on the right, utility of an implant seen in figure A. So now this is a cup with a cage over it. Well, that's a belt and suspenders and then some. So that certainly is going to be beyond a type 2, and it's what about, so it would be either 4 or 5 superior rim, superior lateral migration, or significant bone loss. When you see this, this means there's probably a discontinuity, a high suspicion of discontinuity and significant amount of bone loss. These are definitely type 3B defects. Discontinuity till proven otherwise. These are treated with either these cages, a combination of cup cages. We have some new data on distraction techniques for these discontinuities, but a simple porous-coated large cup does not work in these instances. These are 3B defects and require much more involvement. When we see an x-ray like this, a reconstructive cage with a structural bone graft, this means that the rim is completely incompetent. Unfortunately, in these kind of cases, allograft failure usually is a high rate of complication, and it was without a reconstructive cage, it's 40 to 60% failure. So when you see this kind of a defect, this requires a protection with a cage when there's a discontinuity or a 3B defect. How about combined revisions? We have femoral head and polyethylene exchanges. These are indicated with a stable acetabular and femoral component when there's eccentric polyethylene wear, progressive wear, and the development of osteolysis. We have to have serial radiographs to document that there has been progression. One of the most common complications is hip dislocations. Even though it didn't dislocate the first time, isolated liner exchange, high incidence of instability. You must determine whether or not the acetabular component is in the correct position, and you have to be prepared to change it. Now let's go on to some few more as we come close to finishing here. Combined revision, conversion from a hip arthrodesis, main indication low back pain and secondarily knee pain due to the long-standing arthrodesis. Outcomes, implant survival is greater than 95% at 10 years in these conversions. You have to assess the competence of the gluteus muscles and to predict ambulatory status. These patients must be cautioned that they may need a cane forever. That's one of the big problems. Patients don't expect this and expect a different result. And they have a high risk of dislocation. You have to be prepared to use a constrained liner in these cases. What about femoral revision with uncemented, extensively coated long stem prostheses? Femoral stem must bypass the most distal defect or osteolytic defect by 2 cortical diameters to prevent bending moments through any kind of defect. Cavitary lesions are grafted with particulate graft. Allograft struts can reinforce cortical defects as well as severe osteolytic areas. Femoral paction grafting, morcellized fresh frozen allograft are packed into the canal. Smooth tapered stems into the impacted allograft give the best results. This is the Exeter or the Ling technique. What about some surgical techniques for acetabular revision with porous-coated hemispherical cups? First of all, when the cup is removed, cavitary lesions are identified filled with particular graft. Cups should be placed as inferior and medial as they can to lower the joint reactive forces. Wedge augments are used if the cup is in good position and rigid internal fixation is achieved. Jumbo cups may be lured when a larger reamer is needed to make cortical contact, but we have to be careful that we don't ream any of the columns away just to get a big cup in. Structural allografts may be used to provide stability while bone ingrowth occurs in a cementless cup, but only as a belt and suspenders. If it's primarily used to give primary support, they're high failure rate, as we mentioned previously. Acetabular revision with a reconstructive cage and structural allograft. The polyethylene cup is cemented into the cage, bone graft behind the cage. However, again, beware that these cages have a higher failure rate in 3Bs and discontinuities. Currently, these appear to be better served with the augments and the osteophilic components, such as these various new highly porous metals. And when we're doing femoral head and polyethylene liner exchanges, a technique, you must exchange both the head and liner. You can't just leave the head. And osteolytic defects may be bone grafted through screw holes, but don't go up into the ilium and start making holes bigger. You may compromise the fixation of the cup, create a fracture. Also, there is some evidence to show that even if you leave these osteolytic lesions without bone graft, they tend to fill in later. I think I've tried to give you a summary of a highlight of some of the more common defects in revisions, to recognize what's bad, and when you see an acetabulum, if you see a migration up and in greater than 3 centimeters, that requires a major reconstruction. Up and out less than 3 centimeters, more of a reconstruction, but not as bad. And when there's less than 3 centimeters of migration, you're going to be able to get stable fixation. Femoral revisions, try and make sure you identify the diaphysis. If there's 4 centimeters of diaphysis available, you can get away with a cylindrical stem. If there's less than 4 centimeters of diaphysis, then it appears that tapered stems work better. Beware of the isolated liner exchanges with a higher incidence of dislocation. And I think that I've tried to cover and highlight the areas of periprosthetic fractures as well as revision surgery. Thank you very much for your attention.
If you enjoyed this video, please consider leaving a like. We'd love to hear your thoughts and what you'd like to see next in the comments. Don't forget to subscribe to our channel and follow us on social media.